This is an example of a thromboaspiration in a case of acute dissection of the internal carotid artery. Acute dissection of the internal carotid artery here, acute tapering of the internal carotid artery, and complete occlusion of the middle cerebral artery because there is a clot that's lodged up there, complicated by embolic occlusion of the ipsilateral middle cerebral artery. And then there is a fresh clot here. There is a fresh clot occluding the right MCA and no cross-filling into the ipsilateral occluded carotid circulation. There is no cross-filling into the middle cerebral artery circulation on the side of the stroke. So this is a typical indication of quick recanalization, and in this case it was done by using a large bore aspiration catheter advanced to the face of the clot, and the clot was removed using thromboaspiration as I showed you earlier. And once you suck the clot, there is prompt re-establishment of flow in the normal circulation because the underlying circulation was normal except it got occluded by an embolic clot. So this is an example of re-establishment of antegrade flow using thromboaspiration. So on your left-hand side is before thromboaspiration, and on your right-hand side is after thromboaspiration. If we continue with this cascade of events and look actually at what can go wrong, one can actually divide the time of treatment becomes clicking, the clock becomes clicking from the onset of symptoms in the case of Mrs. Katya at 12 noon. And one can divide the different stages that the patient goes through in acute ischemic stroke. There is first the pre-hospital stage, then the inter-hospital stage, and then the stage in the hospital where there is a stroke center. So the clock starts clicking as soon as the onset of symptoms, and in the case of Mrs. Katya at 12 noon, there are three distinct phases: pre-hospital stage, inter-hospital stage, and in-hospital stage. And each of these stages, unfortunately, can have its own challenges and that delay access to proper treatment and affect the outcome in this patient. Some of these challenges are related to the patient and her family themselves when they do not recognize the symptoms of a stroke or don't call for help and then call for EMS. Even if they call the EMS, sometimes the EMS gets there and is not used to cases of stroke. So delays can happen if the patient is also taken to an intermediate care facility or to an emergency room or to a nearby local hospital that is not equipped to do comprehensive stroke treatment, and the delays occur either from the circumstances or to approve the financial status of the patient. There are numerous delays that can happen, and we need to be aware of these delays and try to minimize them. So why people don't recognize and respond to the symptoms? Because they don't recognize the symptoms. They don't know it's a stroke, and therefore ندربهم ونعلمهم كيف يعرفوا أشياء الstroke. Or they can deny it. They go through a phase of denial or think nothing can be done. In fact, we need to educate everybody that there is a lot that can be done to treat effectively a stroke and to avoid disability and death in these patients. A lot of patients worry about the cost, rightly so, or symptoms will go away on their own. They don't, or they actually are afraid to go to the hospital. And what you see is actually what happens to a patient when the stroke extends. It's really a terrible cascade from bad to worse, and patients end up on the respirator with the trach and the peg. It's really a nightmare. It is a nightmare. Help me avoid this. This is an example in the management of acute ischemic stroke, the clinical outcome. The clinical outcome depends on numerous factors and circumstances. Chief among these factors and circumstances is expedited imaging. Don't waste too much time in the imaging. Please don't waste time into the imaging. Do the necessary imaging, but expedited. Availability of all form of complementary treatments, good neurologists, good emergency room, interventional people, availability of RTPA and availability of mechanical thrombectomy. It's very important to have mechanical thrombectomy available. The state of the collaterals, the poor collaterals, especially if we delay the treatment, will actually be devastating. So the state of the collaterals that varies from one patient to another is very important. And also when we image, we need to image the core, the size of the core infarct, and the size of the penumbra that is at risk, and it is worth actually saving. So this is this is another example of an occlusion of the middle cerebral artery that we successfully removed it, but we did not pay very much attention to the time onset. There was a confusion as when the patient was last seen well, and this is what happened after we reopened. There's hemorrhagic transformation. Actually, most of these hemorrhagic transformations, when they are so bad, actually are lethal, unfortunately. So the time of onset is very important. The stage of collaterals, the state of collateral circulation is very important. The expedited imaging is very important. The time it takes to bring the patient to a comprehensive stroke center is very important. That's the core of the logistics that we face in treating stroke in Lebanon. So acute, accurate, expedited, and timely imaging of the vessel occlusion, the site of the occlusion, the status of the collateral circulation, the size of the core infarct, and the size of the penumbra is absolutely necessary to avoid futile treatment and or catastrophic hemorrhagic complications. And this is what the rapid artificial intelligence software that we have at our hospital gives us. You see the area in fuchsia is actually the core infarct, and the area in green on the CT and CT perfusion is the penumbra. So there is a significant mismatch telling us that if we treat this patient, if we take the clot out, he is very, very likely, he or she will improve. Now, as you can see from these cases, the accurate determination of the time of onset, the proper imaging protocol, especially expedited imaging, particularly imaging of the size of the core infarct and the size of the penumbra, that is the tissue at risk, and the status of the collateral circulation, and the timely transfer to a comprehensive stroke center are all of this very important factors that influence the clinical outcome of patients presenting with acute stroke. It would be very useful and beneficial for stroke patients that we establish in Lebanon a telestroke network, and where community hospitals seeing patients with stroke actually can communicate between the primary hospital, primary stroke center, and the tertiary comprehensive stroke center where mechanical thrombectomy is available. So these primary stroke hospitals or primary care hospitals should be connected electronically with the comprehensive stroke center, and if indicated and if it's timely, if the patient could benefit after penumbral imaging, patients suffering from acute ischemic stroke who are evaluated within the telestroke network that we are hoping to establish in Lebanon and are found to be candidate for emergency thrombectomy, are promptly transferred in an expedited manner to the comprehensive stroke center where comprehensive management of the stroke can happen. This is our stroke center. It involves regular radiology technicians who are trained all 24/7, nursing staff 24/7, emergency room physicians trained in the management and triage of stroke 24/7, neurologists, stroke neurologists, ICU intensivists, anesthesiologists, interventional neuroradiologists, and neurosurgeon. This is a comprehensive, multidisciplinary service whose primary function is the early detection, the expedited imaging, expedited neurological evaluation of patients presenting with acute ischemic stroke, and to follow the comprehensive treatment of these patients using all tools available, either intravenous thrombolysis or mechanical thrombectomy. I hope this was a very short expose on the logistics that we really need to establish to take care of patients with stroke in Lebanon. شكرا لإصغائكم.